Hello, my name's Amer, shoaib. I'm having a bit of a busman's holiday at the moment, and I'm sorry that I can't be there with you. But what I'd like to do is to share some of my thoughts on conditions that need to be referred and what doesn't need to be referred in primary care. We've noticed that the rate of referrals is going up, but a lot of the patients that I see don't actually need to come to secondary care, and I think that these could be dealt with adequately with conservative therapies in primary care. So the conditions that I'm going to talk about are ones that you are very familiar with: hallux valgus, hallux rigidus, hammertoes, flat feet, Morton's rheuma, plantar fasciitis, Achilles tendinopathy, and arthritis of the foot and ankle. Now, if you look at the left-hand picture, that's a picture of a foot in an arboreal ape. If you look at the very right-hand picture, that's the picture of a hand in a human, and there isn't really that much difference in between the two, apart from the old opposable thumb. Now, if you compare the arboreal ape's foot with the human foot, which is the picture in the middle, you can see that there's a vast difference, and that's because in humans who are bipeds, the human foot is a propulsive unit. We split the foot up into three bits: the forefoot, the hindfoot, and the midfoot. But often people complain of problems in one or more of these areas. Hallux valgus, I'm sure you're very familiar with. Patients are basically going to self-select for surgery. There have been various studies which look at orthotics, and they don't really make any difference at all. So the choice really is, are the patients going to wear broader fitting shoes? And if they're happy with this, then great. If they're not happy with their broader fitting shoes, or they can't manage, then surgery is the only other option, and there's nothing else that works. I don't think it's worth taking any x-rays in primary care, because quite often you'll get an incomplete series, there won't be weight-bearing x-rays, and the diagnosis is obvious. The reason we take x-rays in secondary care is because it helps us to plan our surgery. Some of the things that would make me more likely to operate on a person is if they have overriding of their toes, if you look underneath their foot and they've got hard skin underneath the metatarsal heads, or if they're rheumatoid. And surgery works. Most patients are very happy with the results of these. Hallux rigidus is arthritis of the great toe MTP joint, and again patients are going to self-select about presentation. Orthotics do have a role, and a rocker bottom forefoot adaptation or a shoe with a wider toe box may make a difference to a patient and put them off from having surgery. If they're not happy with the orthotics, then the only other option really is to have a surgical intervention, and this can be either through shaving off osteophytes, fusing the joint, or occasionally giving an X-ray guided injection is helpful. Joint replacements are available for the great toe MTP joint, but the vast majority of them have a vast number of complications, and I think they're actually too risky. So I would advise patients, unless they want to wear high heels, I would go for a fusion rather than a joint replacement. Hammertoes is a deformity of the PIP joint, and again, patients are going to self-select for surgery. They're going to turn up just because they're symptomatic. I would be more likely to operate on somebody if they have erythema or ulceration, if they've got pain, if they've got hard skin underneath the foot, underneath the metatarsal heads, and if they've got a fixed deformity. Again, we can offer them high toe box shoes, but unfortunately most patients don't like these, and they tend to end up having surgery. Surgery isn't always perfect, but most people are happy. Flat foot is a particular problem of mid and later age, and one of the consequences of untreated flat foot is that it's going to lead to midfoot and hindfoot arthritis. And most of these patients can be treated with orthotics. Now, one concern that I have about Kingsgate House is that the orthotics they provide tend to be compressible, so when patients put their weight on them, they collapse, and that means they're not giving them the support. That means that they're going to then develop midfoot and hindfoot arthritis. So the orthotics that we use tend to be made out of polypropylene, and they're hard plastic. Patients don't like them at first, but eventually, when their feet get used to them, they find that they're beneficial. So you need to look for flat foot in someone who's middle aged. They may have pain around their ankle on the lateral side or on the medial side. Looking from the back, you can see that this person's got a very valgus hind foot. If the joint, the subtalar joint, is still mobile, then the likelihood is that orthotics are going to be all that they need, and only about 20% of them end up having surgery. So this is a condition that could avoid coming to secondary care, but only if they get adequate orthotics in primary care. Plantar fasciitis is what I refer to as the back pain of the foot. It's one of those conditions that we don't really like to see. There are many causes for it. Patients complain of that they're hobbling first thing in the morning, they can't get their heels down to the ground. After about 15 minutes, that stiffness has settled down, but later on in the day they get more and more pain underneath their heel itself. And the vast majority of these, again, don't need referral. They can be treated conservatively. It's very common for them to have tight gastrocnemius muscle, and this can be tested for with a particular test called Silver Scales test, testing to see how much dorsiflexion can be achieved with the knee in flexion when the gastroc is relaxed, and the knee extended when the gastroc is tight. And if there's more dorsiflexion when the knee is flexed, then that means that the gastroc is tight, and they can have physiotherapy and a night splint. And it normally takes about 3 or 4 months, but they do settle down. If they get pain underneath their heel, then I give them a silicone insole. If they've got any neurological symptoms, then I'd be more suspicious that there's something else going on. If you're going to give injections, then what I would suggest is that you give injections slightly from the side of the foot rather than underneath, because if you inject into the plantar fat, you can actually cause necrosis, and this is catastrophic. I go for a pepper pot approach if I give injections, and I don't really give them that many. Surgery is a last resort. If you want to see the exercises that they should be performing, there's a YouTube link on the screen. Morton's uroma is a swelling of the interdigital nerve. One thing I've noticed is that almost all of these patients come up to clinic and they've already had an MRI scan or an ultrasound scan, and I think that's a complete waste of resources because it's a clinical diagnosis, and I'm going to operate on the basis of their symptoms, not on the basis of a scan. Quite often the scans just don't pick them up anyway. So these patients who've got pain in tight shoes, they're better in trainers, worse when they're wearing heels, and you often find that there's this splaying of the toes as well. If you can get them to wear broader shoes, they may find that their symptoms settle down, or they may benefit from wearing shoes with a spongy insole in them. I think it's worth injecting them before referring them, and the way to do that is from the top, go down almost all the way through down to the plantar skin, and then withdraw and aspirate before injecting. If they get shooting pains going into the toes, that means you're in the nerve, so you need to move the needle. Orthotics can be helpful with the metatarsal dome, but surgery is common for this condition. And if they've tried all these conservative measures and they're still in pain, then they need to be referred. Achilles tendinopathy is unfortunately a disease of those over 30, and it's caused by wear and tear within the tendon. We look for swelling and tenderness that moves when the tendon is moving up and down. It's not worth injecting because, first of all, there's a risk that you could cause the tendon itself to rupture, and secondly, it's very difficult to get it within the tendon sheath. I don't bother MRI scanning these patients unless there's a particular reason. I normally treat them conservatively for at least 3 months, and again with the same eccentric loading exercises with the link here. It's only after that I might consider offering them any surgical intervention. So again, this is a disease that doesn't need to be referred. Foot and ankle arthritis is a different kettle of fish because it's wear and tear within the joint. Unfortunately, if pain management doesn't work through analgesia, then nothing else is, and these patients do need to be referred. So people who've got pain on weight bearing, who've got palpable osteophytes and stiffness, and these are the patients who generally benefit very well from surgery, and they're happy after they've had their operation because their pain has been removed. And here you can see some midfoot arthritis that's been treated with some staples. Here's an ankle fusion, and here's an ankle replacement. And these patients get good results. The other half of my job is reconstructive surgery, so legs that are bent, osteomyelitis, articular injuries and non-unions. So this is a particularly awful injury in a skier who fell down a crevasse about 30 feet, and his feet stayed inside the ski boots, and obviously the rest of his legs didn't. Here's somebody whose ankle is pointing off at 45 degrees to the rest of the leg, and here is afterwards, and it's been straightened out with a circular frame. This is somebody who's got an infection around here. If you look, you can see pus dripping out of 2 wounds on their leg, and we've used a circular frame and various other techniques in order to eliminate the infection, and it's prevented him from needing an amputation. So this is the other half of the job I'm doing, and this is principally what I'm doing at the moment on my busman's holiday. So to summarise, the number of foot and ankle referrals is increasing, but probably unnecessarily so. Many of these conditions should be treated in primary care, and I hope you've got a good idea now of what conditions need to be referred and which conditions are better off being treated conservatively. It's not worth ordering a lot of investigations, because if they're not going to change the management, then it's a waste of resources. There are some of these conditions which would normally be treated in primary care which don't settle down, and this small proportion do need to be referred. And then there are some conditions which are going to need referral regardless, and these are only going to be treated in secondary care. Thanks very much.